it's a real pleasure. It's a real pleasure to me to be here and being invited by my longtime friend Claudio Tirivelli, which I know from more than 30 years. And actually, when I was a resident of internal medicine, I was even thinking in going to Trieste to be with him, but sometimes things does not work. And it's a real pleasure to be here in these yellow webinars. I've seen some of these talks, and I found them actually very interesting. And I would like today to speak about some thoughts related to the heterogeneous nature of my favorite disease, non-alcoholic fatty liver disease, which I've been involved in doing different type of work in the last 20 years. And I always reflect on some things I read. And I think that although sometimes could be obvious that every disease is heterogeneous, some thoughts about this in NAFLD specifically are important. So these are my conflict of interest and not much consulting and some clinical trials I'm involved with. And this is the outline of my talk. We're going to talk about what is under the name and some of the role of genetics and pathogenic pathways.
You have
and
to change that. You have to
disease.
change the slide. I mean, the slide is still close to the first one.
Oh, I'm sorry. Okay. You are seeing now the fatty liver historical remarks, are you?
No.
No.
Just seeing the first slide.
Oh, why is not advancing? Let's see. You're not seeing the
No.
Let's see. I guess I will do it just the regular way. Okay, let's see. Now you are seeing it?
Yes, I see the first one.
Yeah. And the second one?
Yes, okay, it works. Perfect.
Okay. So this is the outline of my talk. We're going to talk about what is under the name of NAFLD and the role of genetic determinants and the differential contribution of some pathogenic pathways, and also the impact of heterogeneity in clinical disease and the implications in clinical practice and research. So some historical remarks. Actually, fatty liver is present in civilization from a long time, as judging from the representation of obesity from the Paleolithic, at these Venus figurines shows that are from 30,000 years before Christ. But fatty liver was not recognized as a disease entity until 19th century, as where histology was becoming available, and these slides from Austrian pathologists from the 19th century represent. But was only Addison in 1836 who introduced the term fatty liver in the English medical vocabulary. It was just in the first half of the 20th century where histological recognition and classification developed. The concept of a NAFLD emerged in the 80s after a seminal publication of a pathologist from Mayo Clinic, where they described liver damage in individuals that do not drink, but has features of those that excessively drink alcohol. And they coined the term NASH, non-alcoholic steatohepatitis, to define this entity, but then was expanded by Fenton and Schaffner in 1983 to non-alcoholic fatty liver disease, which is a spectrum of histological alterations of the liver that include isolated steatosis, the deposit of fat in hepatocytes in the form of the macrovascular features, and the steatosis hepatitis, which is characterized by inflammatory infiltrates, but specifically by the presence of evidence of hepatocellular injury, which is represented by hepatocellular ballooning, which is a specific feature of steatohepatitis. And the whole concept and importance of this idea of this disease is that it may progress to end-stage liver disease, which was not actually recognized before this publication. After the seminal publication of Ludwig in the 80s, there has been an explosion of information about this disease, as that we know is strongly associated to insulin resistance and metabolic derangements. And because the increasing frequency, the obesity and type 2 diabetes, this disease is now one of the most common liver disease in the world. And besides the progression to cirrhosis, it also harbored the risk to, as other chronic liver disease, to the development of obstructive carcinoma. Epidemiological modeling showed that there will be an exponential increase in burden of disease, which is something worrisome for our practice. Currently, I mean, as per the American Association of Study of the Liver, the NAFLD diagnostic criteria, it requires the evidence of hepatic steatosis by imaging or histology, no significant alcohol consumption, and no competing hepatic steatosis etiologies, and no coexisting causes of chronic liver disease. This is the definition that has been in the stage from the 80s and until now, and has been used to generate all the information we now have. And this is the most common graph you have seen in many talks about the worldwide estimated prevalence of NAFLD, that in overall reaches around 25% of the general population. But of course, the quality of this data is limited, particularly in my region in Latin America. So the estimates are not necessarily very accurate. And we need indeed more granular data of the different countries, at least in my region, to estimate the problem. Although if you take into consideration the prevalence of obesity or type 2 diabetes, indeed, this is a very, very important health problem. And as I mentioned before, epidemiological modeling of NAFLD, as shown in these two papers by Estes in Journal of Hepatology and Hepatology, they show the worrisome projections in the next decade about the number of incident cases of NAFLD or NASH, both in the United States, as shown here, or in Europe, as shown here. Indeed, there is a big tide that is coming into us, and that is something that will burden our health systems everywhere. And we are already seeing this in terms of chronic liver disease and also in terms of transplant need of these patients. Also, it's important that this disease has evolved conceptually to the concept that is a multisystem disease. And this stress that the metabolic derangement that underlies NAFLD determines its association with many other conditions, such as heart disease, vascular disease, chronic kidney disease, and eventually some incident cancers. And the relationship between these conditions and liver disease is bidirectional and complex, particularly with type 2 diabetes, where fatty liver is a risk for type 2 diabetes development, but also diabetes is a risk for more severe disease. But the clinical implication of this concept of NAFLD as a multi-system disease is that one, as a clinician, has to pay proper attention to obesity and cardiovascular risk assessment, and particularly diagnosis and treatment of comorbidity. Comorbidities such as hypertension, type 2 diabetes, endocrine disease, kidney disease, and also cancer screening, as these patients have increased rates of some particular cancers like colon cancer and breast cancer. So this is kind of disease that you have to face in the context of a multidisciplinary team, or as a real internist, paying attention to all details of patients. And one thing I could not live without mentioning is the process of renaming of this disease, which is ongoing, and is a sort of a live process that I'm watching, like all of you. There is a proposal, that was stated in the late 2020 and has been ongoing during 21, that proposed to replace the name of NAFLD for MAFLD and this single letter change refers to metabolic dysfunction associated fatty liver disease, as is stated in the slide. And the concept of that is because there are some problems with the name, and actually these are shown in this slide, that there is a question about this NAFLD is the right name because it defines a disease from something that it is not. And the terminology non-alcoholic also trivializes and stigmatizes the disease that needs distance from obesity and alcohol. And in some populations, it's kind of weird to call, for instance, pediatric patients as non-alcoholic. So this proposal to change the name also takes into consideration that there is not a safe limit of alcohol, and is not precise in defining the pathogenic root of the problem, and does not capture, which is the topic of our talk today, the heterogeneity of the patient population with regard to drivers and disease modifiers. And this NAFLD diagnosis is based on exclusion, and therefore this group, which I participate actually, proposed to use positive criteria for NAFLD and have the virtue of allowed the assignment of a dual etiology to liver disease, because sometimes if you have a patient with hepatitis B, for instance, but is obese and diabetic and has fat in the liver, probably that patient has two diseases, and these two diseases you need to balance which is the one that contribute more to the liver damage, but you have to treat both. In that scenario, you can label that patient as NAFLD because has a competing etiology of liver disease. And actually our host, Claudio, proposed something very similar 4 years ago. And before that, in the 2004, there was already reflections about the need to change the name. The group from Australia, from Professor Jacob George and Mohammed Islam, they have put this in movement now, and there is some controversy because Americans, they don't like the name change, and there is indeed problems in translation. The knowledge already generated under the name of NAFLD to MAFLD, but there is something that we need consensus, and the process, as I said, is live, and we have to wait for consensus. In the meantime, in the rest of this talk, I'm going to use NAFLD because evidence is generated essentially under that name. The positive criteria for MAFLD is shown in this slide. As you see, it's a very simple manner to define the condition. You have to have evidence of hepatic steatosis. This is for adults, and the steatosis could be detected by imaging or broad biomarkers of the score or by liver histology. And if that is coexistent with overweight or obesity, you can do the diagnosis, can make the diagnosis. If the patient is diabetic, you can make the diagnosis. If the patient is lean and normal weight and non-diabetic, there is a need of a presence of at least 2 metabolic risk abnormalities resembling the definition of metabolic syndrome. We all know that this is not perfect, but I believe personally that is a step forward in the concept of fatty liver diseases, changing some inaccuracies that are present in the original definition. But coming back to what we want to talk is, indeed, NAFLD is an heterogeneous condition, and under that name, which is an umbrella term, there are very different patient populations grouped. The pathologic process by which NAFLD progresses, by the way, involve multiple molecular pathways that are complex and are incompletely understood. And indeed, the influence of environmental factors, genetic susceptibility, and other modifier risk factors may act in a different ways in the different patients, maybe sequential, maybe parallel, maybe with different hierarchies within the spectrum of disease and also over time. And this is important when we face a patient. And this is a figure of one review that we wrote with some friends in seminars recently that shows the different factors you may consider to contribute to this NAFLD heterogeneity, like age, sex, and reproductive status, genetics and epigenetics, and ethnicity, which is important in our area in particular, the role of microbiome and intestinal barrier, hormonal status, metabolic health as probably one of the most important metabolic roots of the disease, and the modulatory effect of alcohol consumption as that may act as an accelerant of liver disease in some patients. And recently recognized it, I mean, of course, physical activity and sedentarism are very important for this in terms of causing directly obesity, but also in terms of reducing muscle mass, which has been in some way neglected as an important player in terms of regulating insulin sensitivity and eventually causing as producing some agents liver damage. And as I mentioned, all these factors interact in different ways to produce different hierarchy of pathophysiological mechanism, different disease subphenotypes, variable natural history, and variable therapeutic response. And as an example, you can see these 3 patients with the same diagnosis of NAFLD, but the 3 patients may be different in the terms of contribution of environmental factors, genetic or epigenetic factors of poor metabolic health. And these 3 patients likely will have different natural history and different response to different agents. The impact of heterogeneity may be seen in the impact on clinical trials, because trials in general so far do not take fully account of patient heterogeneity and the distribution of diabetic patients, non-diabetic patients, obesity patients, and no obese patients is sometimes not totally compensated in the different groups. And that is likely one of the reasons behind the suboptimal response we have seen in most of the published trials so far. One other problem is that the entry point for the trials is essentially histological. It means you have steatohepatitis, you get into the trial, but this dichotomy must be modulated for different factors we already mentioned. And of course, if you take into account heterogeneity, you should have an impact on clinical management. And in the future, of course, as many tools you can access to, you can refine the management to a personalized medical approach. The role of genetic determinants is very important, as you all know. The contribution to the final phenotype of genetics is variable and must be between 20 and 30%. And the different GWAS carried out in different populations had identified several genes, and this is a short list. There are more, and the most important one of the most strictly linked to damage is a very well-known PNPL3, or the gene that codes for a protein named adiponutrin, that the function of this disease is not completely known, but is involved in regulation the lipid accumulation in the liver, probably in regulating the dynamic of the lipid droplet. And other diseases, like other genes like DMCSF2 regulates the export of lipoproteins and triglycerides from the liver. So most of these diseases, these genes regulate the dynamic of accumulation of fat in the liver, and sometimes they can be regulating the risk also of cardiovascular disease. Indeed, there is an important probability of heritability in NAFLD, and in this paper from JCI in 2017 from the group of Rohit Lumba, you can see that if you have relative of patients with NAFLD, particularly those with cirrhosis, your risk of advanced fibrosis is increased significantly to 12 times. And this is important to register an account when you see patients with NAFLD, which is the family history of them. And as I mentioned before, the gene that codes for adiponutrin, PNPL3, is a stronger, the strongest related to fibrosis risk, which is the more important feature histologically related to liver outcomes in NAFLD. And as you see in this meta-analysis from Sokoyan that I understand that I spoke to you several months ago, the presence of these polymorphisms, I134M, associated to fibrosis in a meta-analysis of several publications made in that year. And the other important thing is that some gene variants disentangles NASH from cardiovascular disease, and this is important in terms of management of these patients that, as you know, collectively, NASH patients have as a first cause of death a cardiovascular disease. But some patients that has, for instance, a polymorphism or gene variants of from TM6 SF2 have more risk of liver disease, but reduces risk of vascular diseases. And this is because they regulate the export of lipoproteins from the liver and determines a non-atherogenic lipoprotein profile in the serum. Some researchers, particular researchers from Finland, have proposed that you can, base it on genetic testing, differentiate genetic versus metabolic NAFLD. Although this might be a sort of simplistic dichotomy, has the basis in the fact that carriers of the PNPL3 variant are not insulin resistant, and then might be a form of pure genetic NAFLD. However, phenotypic expression of NAFLD function is modulated by factors such as adiposity and this metabolism, or even alcohol intake. And probably it's better to, the subclassification should integrate the clinical risk factor and combine environmental and genetic pathway underlying disease predisposition. The challenge ahead will be develop reliable cluster of genetic variants that predict disease subtypes. And as we are going to see in the final of this talk, the use of polygenic risk scores is something that you can foresee in the horizon in the management of these patients. Regarding the differential contribution of pathogenic pathways, I like to show this slide because we have most of the factors involved in pathogenesis of liver damage in NAFLD. And these pathophysiological phenomena may differ, as I mentioned, in different individuals, or may occur in a sequential or parallel fashion with different hierarchies within the spectrum of disease or over the time. And to identify the predominant mechanism may allow to personalized approach. As you see, the general concept is that the disease may start in some patients in adipose tissue, where once the adipose tissues expand, not in a completely normal fashion, start to be insulin resistant, became inflamed, and producing cytokines that affect the liver and increase the free fatty acid that goes to the liver, and in the liver, this increase that is also complicated by increased de novo lipogenesis, cause lipotoxicity and liver cell damage that in turn activates both inflammation and fibrosis. And factors that can modulate are, as I mentioned, genetics, environmental, dietary, essentially, and also changes in microbiota or intestinal permeability. There, one can envision, and this is purely speculative, there are some bases of that in the literature, but you can think in some subtypes where there could be essentially an upregulated DNL, de novo lipogenesis, either by dietary or genetic factors, and in these patients, probably could be those that are essentially isolated steatosis without the inflammation or fibrosis. Some patients that have altered gut barrier or dysbiosis, which is, by the way, important, but it's not present in all patients of NAFLD. Is more prevalent in those obese, and collectively in 30–40% of patients. There could be inflammation predominant subtypes, those patients that have NAFLD in the context of some inflammatory disease like adenitis or polycystic ovary syndrome or psoriasis, which has been conditions that are associated to a more aggressive form of NAFLD. Could be the effective resolution of inflammation or fibrogenic predominant subtypes. So our ability to identify these subtypes in the future could be useful to patient management. One important aspect that has been investigated by Professor Ariel Felsen in San Diego is the resolution of inflammation. It's something that is a little bit hidden instead of the pathogenesis of inflammation. And it has to do with the role of pro-inflammatory macrophages in the liver that when the environment change can suffer a phenotypic switch to a restorative type macrophage that stimulate the hepatocyte proliferation, clearance of apoptotic bodies, or reducing production of pro-inflammatory cytokines with production of anti-inflammatory cytokines, and eventually stimulating matrix degradation and remodeling. In this phenomena, there are some molecules that could be important, that they are called resolvins and can be very important in promoting this phenotypic switch. Also, and Dr. Arias Felsen have a very interesting paper in JCI last year about the role of neutrophil that interact with macrophage and may promote this phenotypic switch. Actually, if you deplete neutrophil infiltration in some model of disease, resolution of inflammation is impaired. So neutrophil infiltration has an important role in this process. With regard to the fibrosis, as I mentioned, fibrosis is one of the most important variables in determining prognosis in NAFLD, and the natural history of this disease is variable and has a lot to do with also which population you study, but there are indeed patients that evolve from NASH to fibrosis, advanced fibrosis, but there are some patients that evolve from NASH to isolated steatosis. And once you have fibrosis, you can have slow progressors and also rapid progressors. And this difference would be very important to recognize, particularly once we have antifibrotic drugs. And one of the things that could be behind us is the possibility that that some functional relevant subset of hepatic stellate cells, the main fibrotic cell in the liver with myofibrillous features, can exist. And this paper from the group of Frank Take in Germany, using single cell RNA-seq, have identified different populations with different gene expression that may be involved in both pro-inflammatory, pro-fibrotic phenotypes or more resolving phenotypes or anti-fibrotic conditions. So this is important and eventually could be identified using advanced molecular biology techniques in liver biopsies, and eventually can guide some treatment once we have antifibrotic drugs. Which are the influence of clinical variables? Where, as I mentioned, these conditions are many and can determine heterogeneity. Of course, it's different, the pediatric population with the adult population, and men with women. As NAFLD has been a lot of research on that, some from Italy, that shows that this is a sexual dimorphic disease. We know that liver pathophysiology is sexually dimorphic. However, preclinical and clinical investigations of NAFLD and and of fibrosis of NAFLD rarely considers sex as a biological variable. This is a very nice review from Professor Stels from Belgium, from France, I'm sorry, that review all the pathways that are male predominant or female preponderant that can cause differences. Indeed, in this disease, women are kind of protected by estrogens and they tend to have a less severe phenotype while they are premenopausic, but after menopausia, they probably equal men or can even have a worse phenotype. So this is important also, as we are going to comment, because women and men seems to respond different to some interventions like diet or exercise. So some personalized approaches are needed there. This is also a recent paper I wanted to show because I found it yesterday in Serie Molecular Gastroenterology and Hepatology that showed that one specific feature like the overexpression of liver pyruvate kinase promote NAFLD and NASH both in mice and human in a sex-specific manner. This is just one example that the disease is a sexual dimorphic condition. With regard to ethnicity, probably besides cultural and dietary habits, patterns, or stuff like that that can influence, genetic is indeed something that that can be partially responsible of disease. In this study that we still do not publish, we assessed the frequencies of PNLP3, TM6SF2 that are, as I showed before, two genes important in determining the severity of disease, and also this hydroxysteroid dehydrogenase 17BO2, which is the protective gene that has been shown on not only for NAFLD, also for other liver disease. And we found interestingly that in Chile, we have lower prevalence of the protective and very high prevalence of the genes that are particularly PNPL3 that are affecting the severity of disease. This seems to be similar for all the Native Americans that are from the Pacific side of Latin America, and likely is the cause of the overrepresentation of NAFLD in Mexican Americans in the US that has been shown that have a more prevalent and more severe disease, also with the overrepresentation of PNPL3. So it's very interesting that Chile has one of the highest prevalence of this risk allele in the world compared with the East Asian, South Asian, European, Africans, and also Amerindians. And this column is belonging to Mapuches, which is our native population that have even higher prevalence of PNLP3, reaching over 80%. Of the risk allele. Interestingly, TM6SF2 has a very low prevalence in Chile and almost zero in Native Americans of my country. The importance of metabolic derangements, I don't have time to get into more details on that, but metabolic health, as long as this may be a vague concept, at least if you consider obesity, feature of metabolic syndrome or type 2 diabetes as signs of metabolic derangements, this strongly impact the natural history of NAFLD, determining a more severe disease and a more fibrotic stage, and of course, more cardiovascular events, as is all known. And this also, you know, the view of this disease as a metabolic disorder have impacted in the use of many drugs that influence on this. But as you know, there are also some therapeutic options in development that may act directly, for instance, in some genetic feature using silencing mRNA techniques or something like that, that may be useful in forms where more genetic predominance exists. Which are the implications for research and clinical practice? Essentially, for research, the clinical trial design should take into account NAFLD heterogeneity and record data in a more granular manner, particularly regarding exercise, diet, group balance in terms of male, female, diabetic, non-diabetic, obesity and non-obesity, etc. And novel trial designs can be envisioned, and this has been proposed by the group that proposed NAFLD as designs like umbrella basket of platforms where individuals with metabolic disease as a whole are included and with the proper disease phenotyping and trying to identify biomarkers or genotypes to use the drugs. Basket that individuals with different types of metabolic disease, diabetics, obesity, that are grouped together, or individuals that are recruited to according to markers. For research and clinical practice, in clinical practice, the genetic heterogeneity could be taken, leveraged by the use of genetic assessment, and particularly by the use of polygenic risk scores, the pathogenic pathway by biomarkers, and the heterogeneity of clinical disease by a more fine risk stratification and referred pathway. The genetic risk score is the sum of the genes that some patient may have, adjusted by their weight in causing disease, and that could be used for NAFLD detection, prediction of NASH progression, and prediction of severe fibrosis. Could be, as of recently published, the group of Luca Valenti for stratification of the risk of hepatocellular carcinoma in these patients, and of course for identification of therapeutic targets of optimization of therapeutics approach. Once we have some ways to modulate PNPLA3 expression, we could use genetic testing for that. But rather than one single gene, we should use a panel of the most important or more relevant genes, eventually combine it with clinical data, obesity, type 2 diabetes, alcohol consumption, and some biomarkers to combine and, you know, do something like a triage in patients with high polygenic risk score or low polygenic risk score, where we can intensify lifestyle management, clinical trials on prioritize for hepatocellular carcinoma surveillance. Interestingly, there is data that I haven't had time to show that patients that harbor PNPL3 allele risk respond better to initiative to cause weight loss like bariatric surgery or lifestyle change programs. Also, the use of metabolomics, and this is a paper which is not published yet is submitted to hepatology. I have the chance to contribute. It comes from Spain, and attempts to use metabolomic for NAFLD phenotyping. In this paper, the metabolomic signatures of patients are similar to some experimental models that are defective in VLDL secretion or are defective in LDL receptor. So resembling sort of patients that have different cardiovascular risk. And this metabolomic approach can differentiate these subtypes. And also the same group before have published that they are able to differentiate between isolated steatosis and steatohepatitis. So this is something still in development. As you see, there is a significant overlap between groups, but metabolomic signatures are promising in this regard. And there is a huge project in Europe, as you probably know, the Litmus project, that is working on this. And actually, Professor Anstey recently published a paper in Nature Review of Gastroenterology about the details of metabolomic and other omics signatures in NAFLD. And the whole issue is to advance to precision and personalized medicine in this condition. We're taking into account all these variables we have talked about, advance to precision medicine that needs, of course, clinical validation, but you have to aim for optimal characterization of patient subgroups using genotyping, phenotyping, use the biomarkers that we're going to have in the future with optimal efficacy, and you can incorporate their predictive artificial intelligence model for clinician, and with that, discover of novel biomarkers and target, with the goal of have treatment options that are specific for different male and female, for different gene background or different status metabolics. And you can, of course, work in combined treatments. So in summary, NAFLD is an umbrella term grouping a heterogeneous population of patients. Indeed, more research aiming to identify disease subtypes is needed, but is ongoing, and taking into account factors and features involved in determining the heterogeneous nature of disease is relevant for trial design and for advancing towards personalized medical approach. With that, I would like to thank you. Thanks again, my friend Claudio, and of course, I will happy to receive questions and discuss about these topics that I found very interesting. Thank you again to all.
Thank you very much. Really fascinating. Really impressed. There's any question or comments or remarks?
Well, I am not a specialist on the, but it really fascinated and very nice the presentation as well. I wonder if this polymorphism in PNL, in adiponutrin, that is so high in Mapuche and so on, is just an isolation for a methionine, if I understood correctly. And nobody has looked at the protein, which are the properties that are altered there. Because you associate polymorphism with NAFLD, but what about the property of the protein? So it could be targeted for therapy, no?
Yeah, this has been studied. There is some debate about the exact function in the liver and also in the adipose tissue, but in the liver, it seems to regulate the size of the lipid droplet. And the polymorphins determine an overexpression of the protein, which is likely an hyperfunction of the disease and of the protein, I'm sorry. And there has been attempts in animals using antisense oligonucleotides against the protein that actually decreased fatty liver content. Okay. So it's a actually there is efforts to use this as a therapeutic target.
Okay, thank you.
Any other question? Well, I have a question. I mean, almost a comment. I mean, of course, you demonstrated quite nicely and convincingly that each patient is different from the other. And actually, NAFLD is a big melting pot under which we are going to put a lot of different things, which sometimes are really hard to be comparable. But there is a trend which is also very clear and which always impressed me very much. Why, by moving from a mild disease, fatty liver, to a more severe disease, NASH, to an advanced disease with a cirrhosis and then cancer, the amount of fat is decreasing. I mean, if you look at the cirrhosis, although in the early stage, functionally still working well, the liver, the amount of fat is 0. So the question is whether we are now looking at something which is not only evolving, but also is changing the rules of the game. I mean, in the early stages, when you have fatty liver, pure fatty liver with hypertension, metabolic disease, disorder, lack of exercise, you name it. I mean, you have a lot of fat, but a mild damage. Moving on, you have a higher damage, but much less fat. Do you have any, idea how to explain this?
Yeah, well, it's an interesting question. What is called burnout NASH is, you know, when you have the disease and the metabolic companions that are usual, but you actually have reduced levels or even no fat in the liver. And that is actually a question I have researched in the literature, and there is no a fine explanation for that. Most of people regard this phenomena as something that is related to changes in hepatic microcirculatory that allows to decrease the overflow of fatty acid from the adipose tissue to the liver. So there is a sort of chant of some of those molecules to the general circulation. But actually, I haven't found an explanation, a clear explanation of this. Also, it could be that that de novo lipogenesis, which is very active in earlier stage of the diseases, likely by different changes in, but this is just a speculation, in the inflammation or local inflammation could be not overstimulated like in the beginning of the disease. But this is not something that has been deciphered as far as I know.
Thank you. Any other question? Well, if not, thank you very much, Marco. You did an excellent job. We're grateful to your presentation. And I think we see each other tomorrow for the Annals of Hepatology meeting.
I see.
You take care. Ciao, ciao.
Ciao, ciao. Thanks a lot.
Thanks to you.
Bye-bye.
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 Thank you. Bye.